Hello and welcome to Ask Us Anything, your opportunity for a free webinar on Sundays where the ID co-founders come together and answer some of your anatomical questions to the best of our ability. I'm one of your co-founders and hosts, Dr. Kathy Dooley. I am a chiropractic rehabilitation specialist, budding acupuncturist. I'm trying to live in the lines of Anna Folkmar, amazing person, and also working really hard to understand better functional medicine, and I'm an anatomist. Dr. Anna Folkmar is with us, also co-founder.
Hi everyone, Dr. Anna Folkmar here, one of your co-founders and co-hosts for today, and super excited to see what questions are thrown at us.
And definitely not least, what mentioned last here is the amazing anatomic artist, Danny Quirk.
Hey everybody, Danny here. Yep, one of the co-founders with these two, and then excited to be here and talk about anatomy for the day. So.
We've got some really good questions, and then at the end of the talk, we've got a special ID product. It's our first big product besides our DVD we're pretty excited about. It's been 6 years in the making, and we could be more excited to just talk to you about it and show you what we have in store for you in the next week. So we have a question about plantar fasciitis. The question is kind of general, like what are our thoughts on plantar fasciitis? And we have a lot of thoughts on plantar fasciitis. I've been studying plantar fasciitis for a number of years, and I know these two folks are fascinated in it. We talk about plantar fasciitis quite a bit in our ID2 lower extremity concepts course, as well as ID6, our movement subsystems course. But we'll give you a quick briefing on plantar fasciitis. Plantar fasciitis is typically, it's a misnomer, by the way. The plantar fascia, if you will, is an aponeurosis. It's a broad, flat tendon. And fasciae is kind of a looser connective tissue. And when it becomes an aponeurosis, it's highly collagenated, and it's a source for muscular attachment. So it can anchor to a site. So the plantar aponeurosis is more of a tendon than it is really fasciae. And what's so interesting is then the most recent research on plantar fasciitis, they're actually calling it, they're calling people out for calling it an inflammation, because it's not. Plantar fasciitis is most commonly a tendinosis. It very much resembles a tendinosis of another tendon, like you would have in the patellar tendon or you would have in the Achilles. And so we're trying to get away from the itises that the itis by definition is indicative of an inflammatory process. And so what they're finding is that the plantar fasciae, the three bands of it, thicken towards the anterior calcaneal attachments. And so most of the plantar fasciae, using quotes, attaches to the medial calcaneal tubercle, and then can anchor a little bit to the lateral calcaneal tubercle. And there's three bands, a very large medial band, an intermediate band, and the lateral band. And this very thick aponeurosis is a source of attachment for muscles like quadratus plantae or flexor accessorius, also the flexor digitorum brevis, which helps you to flex the toes, just not all the way to the distal interphalangeal joint or to the proximal interphalangeal joint. And this tendon, if you will, starts to get built up if you are very forefoot dominant, and then suddenly start to go into a heavy amount of heel strike. Now, the important part to understand about plantar fasciitis is the plantar aponeurosis is allowing for a floor, if you will, for the passage of two very important nervous structures with their vascular bundles. And it's the medial and lateral plantar nerve artery and vein. They're branches of the tibial nerve and the posterior tibial artery, which is a branch of the popliteal artery in the back of the knee. So basically, things that are emanating from the back of the calf are heading through the tarsal tunnel, splitting, and they're running deep, or I should say superior to the plantar aponeurosis, and then branching out to go to the distal parts of the foot. So the problem is that people that aren't trained in nerve flosses or nerve floss pendulums like we do in ID5, or they aren't trained in giving a good neurological exam like we train in ID5, they mistake plantar fasciitis for tibial neuropathy that's happening in the foot. So the tibial nerve is giving rise to the medial and lateral plantar nerves, right? And there's also that vasculature. So if the person's having a lot of foot cramping or having a lot of tension along the medial or lateral arch lines, you have more work to do than just to call something plantar fasciitis. Now, my big annoyance with it is that you go to a podiatrist or just a foot therapist and they tell you, well, just solve the problem with an insole or an orthotic, or put a lift in their shoe, wear an inch heel. I can't tell you how many times in my 13-year career I've heard that story. And then, it's just very dismissive. It doesn't solve the problem. It's basically painting a rusty fence. The rust is still there. And so as soon as the person takes the shoe off, these people won't even walk barefoot. And then the risk factors for plantar fasciitis are hilarious. They're like, if you have pes planus, which is flat foot, or if you have pes cavus, which is an arched foot. So if you either have a flat foot or a heavily arched foot, you're at risk. It's just like, who doesn't have one of those two? So it's just really, and the research is really dismissive. But the one thing that we can agree upon is that the name needs to change from plantar fasciitis to plantar tendinosis, and the fact that it's more of a tendinopathy than anything else. And the person, needs to be able to have good mechanics through the foot. A lot of them have very weak intrinsic foot muscles. Many of them are heel wearers, and then suddenly go flat with the foot, or maybe they were used to walking on a flat surface and they suddenly go hiking. These same people are the same risk factors for Achilles tendinopathy, which is why the two tend to go together very nicely. And there is a functional sling underneath the foot that kind of transmits force from the plantar fasciae over to the Achilles tendon. So it's very, very common for someone with true plantar fasciitis, as it were, to have a lot of ankle stability problems. And so in immaculate dissection, the way that we approach it is find out if the plantar fasciae is sending poor signals up the kinetic chain on ground force contact, or if it's a back stability problem, even radiculopathy, of the L4/5/S1 nerve roots, or if it's tibial tendinopathy, or tibial polyneuropathy. So the person's medial and lateral plantar nerves branches, the calcaneal branches off of tibial nerve, are affected due to tarsal tunnel problems or peroneal tunnel tendon problems. So it's not an easy thing. It's not an easy thing like, hey, give them a golf ball and roll it out and hope for the best, or let's get some shockwave therapy, which they have shown is effective. But it's kind of like, we at ID approach it very differently. We approach it from functional movement. We put people through a gait analysis that we make very simple in ID2 by having them do single leg stands and watching the way that they compensate. And then we put them in kneeling and take the foot out of it and see if the foot was a driver of dysfunction. If you want to learn more on how we treat plantar fasciitis, it's just too much to cover in, a 10-minute synopsis. But our big thing, that my take-home point from the ID team would be, make sure the foot is the driver of the dysfunction, and certainly don't just give them a golf ball and hope for the best. A lot of times these people are given a towel and told to do towel pickups with their toes. And that might be okay for the people with pes planus, but it would be awful for the people with pes cavus. And so since pes cavus is a risk factor for plantar fasciitis, then half of your patients might be okay and the other half might not be okay. And we don't even know if the foot is the problem, the foot is the driver, and you haven't also ruled out if it's tibial neuropathy that's the causative agent. Anna, you want to talk about that a little bit more?
As a person who has picked up literally 500 trillion thousand marbles with her toes, yes, I would like to say something. No, when someone comes in, I think that just like you said, we've gotten into the habit kind of as a rehabilitative community of just calling everything on the bottom of the foot, plantar fasciitis, like all, and not even, the practitioners, but a lot of the patient education has sort of been led to think that, anybody that has pain on the bottom of the foot has plantar fasciitis, and foot pain and plantar fasciitis have unfortunately become synonymous, and that's just not the case. So when people come to us, it's kind of like, oh, interesting, you have a foot symptom. Let's learn more about your foot symptom rather than, pathologizing it as a foot problem, particularly if it's bilateral, right? Because if it's both sides, I'm not going to just treat both feet. I know that I've been taught how to jam needles into the bottom of somebody's foot and cup their feet and scrape the bejeebas out of it and, do all kinds of foot exercises and things like that. And, I'm not saying that palliative care doesn't have a place here. It absolutely does. It just can't be without understanding the role of this foot symptom within the holistic view of the person. Because, if you've got ribs above the pelvis that can't breathe to help stabilize the pelvis. And you've got, you know, things below, you've got feet trying to go, oh, hold on pelvis, let's situate you this way. You know, you can't just let that person go out and start playing with their feet and bringing all this, like, you know, somatic awareness to their feet and just feet, if it's only one very small puzzle piece. So, you know, we probably start to sound like a broken record here. Nobody gets a pass. It's a foot symptom, not necessarily a foot problem. It may not even definitively be what it's being called. So, you know, cool. There's foot pain. Let's look at it some more. Let's figure out what's actually going on.
My space bar wasn't working, sorry. This is a trick that Anna Folkmer told me. I have to agree, like, I've not once in my clinical practice, not in 13 years, found plantar fasciitis that it was actually the site of the problem, was actually the source of it. And I have found, you know, the occasional outlier where an ankle sprain or what have you is actually caused by the foot, you know, creating the ground force contact problem up. But as we talk about in our ID2 coursework and ID6 coursework, it's you have to determine if a foot is a driver or dysfunction, like Anna's talking about. And they have plenty of somatic awareness at their foot if they have plantar fasciitis. It's probably, you know, the thing that's keeping them out of trouble. It's like the hardest worker in the group project. You know, do you really want to send them on vacation? Or you want to just tell them, oh, you're doing a good job, and then hope for the best out of them? Or do you want to get the people that are not really participating in the group project to actually get off their ass? I've never had this problem as an ID co-founder. Anna and Danny continue to outwork me on a regular basis, and I didn't even know that was possible until I met the two of them. And so I don't really have this issue in ID, but I have been a part of group projects where my lazy coworkers weren't doing the job, and I would end up exhausted and end up complaining, and all I had to do was, you know, tell them I need your help, and maybe, you know, get that to coordinate. And that's what Anna's describing is really assessing, you know, pelvic stability and how it can relate to the foot. As we've seen in research, the pelvis is kind of like this rotoscope, and so is your, you know, a gyroscope, and so is your talus. And so these two things are working together to orient where you are in space, and you have to find out who the driver of dysfunction is. And you can find out in less than 30 seconds with an ID2 assessment. So it's pretty much just assessing, you know, where the primary dysfunction is for the body. And yes, Anna's right. Give them palliative relief if you want to rub some ice on it, you want to do whatever. And as long as it's not the only thing that you're doing. If you're getting shockwave therapy, which is highly promoted for plantar fasciitis, I've had many patients fail shockwave therapy. They read the research and they're like, it should have worked and it didn't. I'm like, well, it needs to be more multidisciplinary than that. If shockwave therapy would work, if there was an inflammatory cascade and if there's tendinosis that's limiting range of motion, then, you know, you can get rid of some of the fluid, you can break up some of the tissue and get things moving, and circulation improves. But if they're going to go back to the same pattern that got them into trouble, expect more tendinosis. And that's the problem with tendons, is that they need heavy, slow resistance. They need to be repatterned, because if you keep doing the same thing, expecting a different result, it's not going to happen. Tendinosis by nature, we talk about in ID 1, 2, 3, 4, 5, and 6, less than 5, but definitely in 1, 2, 3, 4, 6. We talk about how tendons, if they develop tendinopathy, they ignite mechanoreceptor type 3 that goes up to the parietal lobe, and it causes cortical inhibition, which means they're going to be super tight in that whole area. Tightness is a way for the body to protect itself from excessive range of motion. And it happens through spindle cells, Golgi tendon organs. It's a very, very proper response. But what ends up happening to the athlete or to the person with plantar fasciitis is they get really, really good at their bad pattern, and they can't find a way out of it because they keep repeating it. So you can break it up all you want with shockwave. You can do, if you want to put needles in it. I don't think Anna's really going to be real eager to put a needle into the bottom of someone's foot at the plantar fasciae, because the person might not come back. It's very painful. And then, or gua sha tools or Graston tools, start digging in there. I'm not going to do that. You can't pay me to do that, because, you know, Anna and Danny, I know how much anatomy is right there. Danny does the dissection for this in ID2. There's so much anatomy packed to that area, including a nerve, artery, and vein right there. It's probably not a good idea. Nerves and arteries and veins don't like to be compressed. And part of the problem of what they may be feeling could be compression of the neurovasculature by, you know, a tendon. So you have to be really, really careful just aggressively treating a spot. I mean, I can press on it and that'll inhibit ascending pain to the brain. Doesn't mean you fixed anything. That's just mental trickery. So in ID, we're really into getting to the root cause of the problem. So the first thing we do is clear them for an L5-S1 radiculopathy, sometimes L4 to the floor a little bit. L4 disc herniations aren't as common, but an L4, L5 disc herniation can affect the L4 nerve root. So, you have to clear them for radiculopathy. So we'll run an MRS test that we teach in ID5. And then once they clear that, we can put them through a nerve tension test, make sure that it's not nerve that they're feeling. You can eliminate that in like 30 seconds. It's super fast. And Anna's got some cool dances for this. We've got myotome dance, we've got dermatome dance, we got reflex dance. We have so much fun in ID5, it's ridiculous. So after you learn that quick assessment, you can clear them for that. If you clear them for that, then you can start to say, maybe this is like the nerves eliminated. Let's actually look at this as possibly being a tendinosis, a thickening. And it won't be hard for you to find the research on that. It's right there. They're starting to really pick apart plantar fasciitis, and it needs to be stopped calling it itis. So hopefully that helps. I think I've told this story many times at ID courses, but in case you guys haven't heard me tell this story, one of my favorite doctors, Dr. Philip Snell, he's a rehabilitative chiropractor in your town, Danny, in Portland, Oregon. And he's one of the best chiropractors on the planet. He's also avidly researches everything that comes out of his mouth. He's very trustworthy. He's very evidence-based. He's a brilliant practitioner that I trust a lot. He's very into self-sufficiency, though. He, developed a whole myrehabexercise.com where you can, invest in your own rehab exercises. He's just great. And he talks about how plantar fasciitis a lot of times is misdiagnosed radiculopathy or misdiagnosed tibial neuropathy. And I have to agree with the anatomy down there. So make sure to clear the nerves. And once you clear the nerves, then start to think, is this a hip as a driver of dysfunction, or is the foot a driver? So if you have no idea what I'm talking about, probably need to take ID2. Anna and I talk about it being our favorite. Danny, do you have a favorite? I can't remember. What's your favorite?
I'd say it varies from time to time, but I personally really enjoy core and upper. So
yeah, so Danny's 1 and 3, and Anna and I are 2. We're balancing it out.
I freaking love 2. It really is. I can't pick a favorite, but if I had to pick a favorite, it is hands down 2, because I love, there's so much anatomy covered. Even just doing the foot, right? Because we have the foot in the whole lower extremity course, and even, you get to sort of somewhat the end of the course, and then it's and now we're doing the foot. It's like 4 layers, and Danny's just sitting, and it's amazing. And it's really hard to try to say that everything in the bottom of that foot that's creating a symptom for you is plantar fasciitis. That's definitely
it's just the bucket term, man. And
yeah.
I've seen so many people come to me and say they have plantar fasciitis, and they're pointing to I don't know, here. And I'm like,
right.
And so it's a fascinating study. There's so many things that can cause heel referral that you have to be able to have a really good standard operating system. And if you don't, then we highly suggest you develop one. But as far as some key take home points about plantar fasciitis, don't just assess the foot, assess the system, and then clear them for neural referral. And, there are also blood vessels there. So clear them for, any systemic stagnation. If you see, varicosity in the leg, coming up the leg, and ID2, we also talk about that and how to, give people proper corrections for that. You have to look and see that there could be neurovascular compression, stagnation, irritation, neuritis, or plantar fasciitis or tendinosis, whatever you want to call it. So also in that same differential is heel spur. So you have to look at and see if this person is pounding that heel into the floor and they actually have a spur. So hopefully that encapsulates the discussion on plantar fasciitis. We had another question, a question about palatal expansion and how it affects the body's postural capabilities. I have a massive antagonist to palatal expansion. I know it's all the rave. The palate, the hard palate, is created by the maxilla, the palatine process of the maxilla, and there's a horizontal plate of the palatine bone. It's a small bone that most people don't even know is there. These bones compose the hard palate, and the hard palate maxilla also holds the upper dentition. The upper dentition is much less movable, if you will, and under less stress and duress than the lower dentition, because the lower dentition is part of the mandible, and the mandible articulates with a condylar joint at the temporal bone's mandibular fossa. So a lot of times people will get maxillary palatal expansion to create a better bite. And it's funny, I just filmed a video that we're posting tomorrow about the occlusion and the overcrowding that occurs. We have some study groups coming up on ID Collaborative talking about it, but I'm pretty obsessed with it because my patients are getting recommended to get palatal expanders, especially children, and then lower dentition, they're telling them to get Invisalign. This is thousands and thousands of dollars. And first of all, we talk about an ID4 and again an ID6, how important the jaw is for stability motor control. Your jaw is shown in research that if it just shifts a couple of millimeters, that it shifts the weight in your feet a couple of millimeters. And what the researchers are determining is that we are a kinetic system, that there's not singular parts, and comes back to that old song, the foot bone's connected to the knee bone kind of stuff. But it's true, like if you, and we even do this in classes like in ID6 where we have people shift their jaw and feel their body weight shift into their feet. So you change the bite, you change the body. You change the body, you change the bite. The whole thing changes. So what's very special about why I don't like palatal expanders is because a lot of times the problem is not the palate itself, the hard palate. It is a fixed point for a lot of the moving parts, like the maxillary tuberosity, for instance, is an attachment part for the medial pterygoid muscle that attaches to the mandible. And so if you think about it, if you change the palatal position, you're absolutely changing the articulations of the temporomandibular joint. So I, rather than put a palatal expander in, I say, well, what actually changes the bite? What actually is happening in children and in adults? And why are their teeth overcrowding? Why is there malocclusion? And the research is pointing more and more towards mouth breathing being the reason. And I do a simplistic version of this in the Instagram tomorrow that you'll see, but it starts kind of like this. Most of your breathing should be through the nose, right? It shouldn't be through the mouth. And so that's an ID. We'd make all your inhales through the nose, and only in tension breathing do we have you exhale through the mouth with a shh or a s, right? If you have jaw tension, we just have you shush, so that you can just stay relaxed, the teeth stay separated, and that you don't build jaw tension. Because when you mouth breathe, especially in sleep, what will end up happening is this: you're laying supine, the sinuses, either due to allergenic responses, due to sometimes anatomical relationships, but most of the times it's an allergy response to dust or to smoke or to whatever's in your room. Could be digestion stuff, microbiome issues show up in the nose. Anna will tell you all about how large intestine ends up in the nose, and that's the acupuncture pathway. And they didn't make that up. There's a huge relationship to your dentition and your microbiome. So let's say you have all these gut troubles or allergies or what have you, and then you lay down for sleep and you can't breathe all of a sudden, because your sphenoid sinus is getting clogged and then you can't get the air out. Your nose now starts to stuff, and so you'll drop the jaw to be able to breathe. When you drop the jaw to breathe, the genioglossus muscle of the tongue starts to push down and backwards, taking the epiglottis and pushing it over your airway, otherwise known as sleep apnea. It doesn't even have to be classified as sleep apnea. It just is a constricted airway rather than a dilated airway. Genioglossus has the power of dilating your airway when it goes up to the roof of the mouth, which is why we cue your tongue up in immaculate dissection. So when people have jaw problems, and when I say jaw, I mean temporomandibular joint, they end up mouth breathing, tongue goes back, and then you're still not breathing through your nose, right? Where your nitric oxide receptors are. So your body says, well, that's not good for air. Let me go into CPR position. So you'll go into cranial extension, and it's called the cranial cervical mandibular apparatus, or stomatognathtic apparatus. And so you end up doing that, and then the teeth start to hit each other. And that causes the force to grind the teeth together. And then the jaw starts to shift, deviate, and then you start to develop overcrowding. So rather than put a palatal expander in, you might want to consider first clearing off the nose, really retraining the jaw and breathing. And so I think a lot of people don't do that first before they do a palatal expander, and then they get a palatal expander put in, which I think is really strange way to start things with. I mean, my thesis advisor was a craniofacial specialist. He's a PhD in craniofacial development. And I can't imagine what he would say if I would say, hey, people are putting palatal expanders in to make their teeth sit better. And he'd be like, what? Because the reason he would say that is because the joints are basically synostosed between the maxillae and the palatal. There's sutural stabilization, which is not very movable. And so by expanding that, you're forcing the teeth apart, you're forcing the dentition to be different. And yeah, you're going to get a hell of a lot of postural sway. You'll get a hell of a lot of postural sway and changes in the body when you shift a jaw in either direction either. So you change anything in the mouth, you will absolutely change your proprioception all the way down to your feet. It's right there in the literature. It's not ID theory, although it's ID supported. Anna, you have recently had fun things with your teeth. I know you'll have a lot to say about this, and you are very, very wise when it comes to dentition. I'm fascinated by it. I work for the New York University College of Dentistry, but I still feel like my knowledge is still growing. You and Danny have both experienced some pretty invasive teeth things, and you shared them on our root canal learning hour for ID Collaborative. Do you have some things to add about palatal expansion and the postural sway and our ability to be able to change proprioception via the jaw?
Yeah, I've always wondered. I had a lot of dental work done as a child and had some familial things going on that caused me to have oral surgery and teeth removed, and I had orthodontics and all that stuff. And at one point, we talked about this on the collaborative, but at one point I had teeth that were missing while I had braces in, and the answer was to kind of just shove my teeth together. And I've always wondered what that must like. Where did my spatial awareness go after that? Like when you have holes in your mouth and then you take your teeth and kind of move them in a bunch of different directions, you have so much proprioception here, and your body knows, where it is in space because of a lot of different clues, that are sort of planted around, and your jaw can really influence that. And so, just like you said, teeth are gonna, teeth and the movement of teeth. I had braces from the ages of probably 11 to 14, maybe, like pretty typical braces. And I do wonder how that changed my movement, what my movement was like. Like, I wish I could go back with a different, experience and kind of assess it. But no, I think that, whenever somebody is considering a lot of these techniques, we always ask the question, why? In which case, now this question that was submitted, it doesn't really become that different to the plantar fasciitis question, in the sense that, like, cool, there's some stuff going on in your mouth. Like, let's look at it within the context of you, the human person. Because, if you're mouth breathing at night, why are you mouth breathing at night? Is it purely positional? Is it because you can't breathe your nose? Is it because you've got chronic sinusitis? Is it because your diet is contributing to your chronic sinusitis? Is it because your ears aren't draining appropriately? Like, now there's so many questions, and I don't think that we can just kind of, I think that this is an example of our proportionate bias that we have kind of as a society, in the sense that it's like, oh, well, there's a loud dysfunction, it must mean a loud problem, so let me go after the loudest thing. And our assessment strategies can't start and end there. Mouth symptoms, okay, interesting, but just scrape the surface of that rabbit hole and you will find that those mouth symptoms are giving you clues to, all of the cavities in your head. They're giving you, clues about your gut, about your cardiovascular system, about the state of your lungs. About the state of your peripheral vascular system, about the state of your ability to regulate, insulin and pH. Like, there's just, it goes on and on and on and on. So I don't know why it would necessarily just start and end with palatal expansion without considering it holistically in terms of the context of the person as a whole. And yes, if you just go, there's some teeth stuff, let's just shift your teeth, knowing how the mouth is just one puzzle piece, you can't expect the whole puzzle to not then totally change if you just kind of aggressively manipulate. It is kind of aggressive. Like, palatal expansion is like
it's 100% aggressive. It's 100% aggressive.
Torture device in your mouth.
It's so aggressive to change what's considered to be a non-movable joint. And
rapidly too. Rapidly change it.
We're talking about multiple and by non-movable, I mean very limited movement, not amphiarthrodial like the pubic symphysis or the intervertebral discs, not synarthrodial, not diarthrodial, but synarthrodial, meaning without a lot of movement. We're talking about forcing things that are gomphoses, right, and relative to sutural. I mean, these are the two classifications of synarthroses, right? And we're trying to force that open rather than looking here and looking systemically. I feel like before you do a palatal expansion, you should definitely rule out the other stuff first. I feel like braces are put on kids at 11 to 14 when they're still doing maturation of their development. I find that to be very odd. And especially when, you know, the overcrowding that Anna's talking about it is, and, you know, palatal position relative to the mandible is related a lot to mouth breathing. So, yeah. If you're working with someone with a palatal expander, you have to educate them. Like, look, every moment that you wear this, you are changing your position sensing. The jaw is innervated by mid pons, the middle of the pontine portion of the brainstem. The pons is embryonically from the same place as the cerebellum. The cerebellum is the master of motor control for the body. It does 97 to 98% of all unconscious and conscious proprioception, position sensing. So the pons and the cerebellum are connected by these 3 sets of legs. It's like the 6-legged freaky thing. And pons means bridge. It's a bridge between the 2 parts of the brainstem and between the 2 cerebellar hemispheres. And so these bridge-like structures are axons traveling back and forth to pons and cerebellum, basically saying, you know, what's going on? Can you help me out? Do you have anything that can kind of help me? And so if the middle of the pons is the center where the largest peduncle is for the most amount of axons communicate between pons and cerebellum, you have to think embryonically, if your bro's from the same area code, you're going to go to your bro who knows your neighborhood. And so the pons, that's why people bite down. They've shown in research that if you bite down, it eliminates postural sway. And if you open your mouth, you're basically opening your environment up to accept new proprioception. And it's not hard to find this research. If you come to the ID Collaborative talks, we share all of them with you in helpful links. I mean, we've collected a litany of research on this stuff. And so, and it's growing, it's a growing body all the time. There's more and more articles about it. So our advice, if you're working with someone with a palatal expander, is say, what is the outcome? Are you also looking at your gut? Are you also looking at things? And then you really want to make sure the best palatal expander you've ever had is your tongue. Your tongue was the original palatal expander, as well as your muscles of facial expression and mastication. So you're going to be if someone has a palatal expander in, which I've worked with before, woo, they are in for weekly visits because we have to change their homework all the time because, micrometer of change is a massive change for postural sway for the body. So I personally try to talk them out of them and do other things first before they jump that gun, especially if it's a child. I'm like, before you do palatal expansion, can we please talk about mandibular setting for malocclusion and overcrowding, which is mouth breathing? Yes, it's freaky. The suggestions I'm going to suggest are taping your nose open and taping your mouth shut, which sound nuts. Doesn't sound more nuts to me than a palatal expander though. And it's cheap. 50-cent paper tape, couple dollars on breathe right strips and changing the environment of the nose. So check out our Instagram tomorrow if you want to watch a video of me describing that, but we'll go into quite a bit of detail on that. Cool. Another question we had is about, in our immaculate dissection classes, we talk a lot about tightness as one of our forms of assessment. So someone was asking about like why we choose tightness and the kind of mechanism behind that. The tightness to us is being able to palpate a tissue of interest regarding our functional movement assessment and regarding the person's chief complaint and certain clinical pearls that they tell us in the clinical practice during our auditing process. And tightness to us is a palpatory thing that is both objective and subjective. The person can actually feel a tight wall of tension, and then I can feel that same tight wall. Like Anna was talking about how someone has pain, and we might assess an area that has pain for the person, but they don't actually have tightness. And so that's what we call functional painful. It's borrowed from Gray Cook's selective functional movement assessment, where they classify things as functional painful and dysfunctional painful, functional non-painful, dysfunctional non-painful, which I think is a beautiful terminology that Gray has developed. And the problem is that we have to keep as objective as possible about our patients. We have to be able to keep things more signs rather than just symptoms. They're reporting the symptoms as clinical pearls, and then we look at the signs. And so tightness is palpatory tension, palpated by both the practitioner and the client. And so if they feel tight and I don't feel that they're tight, they're most likely feeling a tenderness, right? Or maybe a decrease in blood supply. But a tight wall of tension that we palpate is usually a muscle responding with its spindle cells. And so the muscle has this amazing feedback system to prevent itself from tearing. And so it keeps a certain amount of tone due to being able to let its antagonists contract so it doesn't tear on a stretch. And this tone is modulated by the proprioceptive system, by the dorsal column mediated system. So the same thing that position senses you has a lot of feedback in that same pathways towards afferents back up to the parietal lobe to tell you where you are in space versus how much tone you're actually having. And some of this even stays local to the spinal cord and basically doesn't need the upper motor neurons to really control it that much unless they're completely knocked down, and they can't dampen the signal. And that's something called myoclonus, where something will just respond over and over and over and can't stop responding. You probably have seen that in stroke victims or people with an upper motor neuron lesion. So the reason why we check this is because it's objective. And so it's not all of our assessment, it's a part of our assessment that one of our colleagues, one of our friends from the NKT world, Simon Jones, he teaches in UK, he talks about, in Europe, he talks about normal tone, leave it alone. And we like to quote him a lot at ID because that quote is a fantastic quote. If something is like squishy and has normal tone, then it's probably not worthy of a lot of my attention. If something's holding on and has its parking brake on because it feels like it's rolling down the hill and increases its tonicity, it's certainly worthy of our attention, which is why we focus on tightness. And so when it comes to dysfunctional movement assessment, we use a standard operating system and a flow chart. And then we also use an assessment checklist in ID in each of our courses, with the exception of 5. So we look and say, well, mostly ID 1, 2, and 3, and 4, because we're going over individual structures. And we look for our movement assessment, and then we palpate. We don't palpate before we do a movement assessment. We do a movement assessment first to give us an idea of where to go, right? Who is our driver? And then we go into palpate to see where someone's holding what we consider to be necessary tone to be able to keep themselves stable. And so when it comes to stability motor control and your ability to be able to stay in control, it creates tonicity to immobilize you. And that's why you have to distinguish between a mobility problem and a stability problem, which is really hard for a lot of people. But I think with a couple of skills, you can start to develop, like, why do people stretch something because it's tight? Why do people do that? Because they have an awareness of a tissue and they think the appropriate response is to stretch it. Why is that? Well, they're trying to get blood flow to the area. They're not necessarily doing a bad thing. They're just not necessarily doing the right thing. And in immaculate dissection, what we try to do is stop just stretching things for the sake of stretching them, because sometimes things are on stretch and that's why they're tight. The tonicity is increased in the spindle cell to decelerate the motion to prevent the tearing. Anna, do you have more to say about why we assess tightness?
Yeah, I mean, you know, when I'm teaching muscle phys, and one of the schools that I work for, I always talk about how if I take my dog for a walk and he runs and tries to run out into the street or something, I'm going to pull back. I'm going to pull back his leash so he comes closer to me to protect us both. And if somebody came and tried to separate us, I'd have to murder you because that's my dog. And no, that's not okay. It's a protective mechanism. If you just come and try to, you know, separate us and get rid of this, you know, tension action that just happened, that would be bad. So, you know, I muscle phys is one of my absolute favorite topics because it's literally, you know, we think about global growth movements of muscles going long and short and all that stuff, and it's wonderful. But then when you take a deep dive into it and you go into the thing inside of the thing inside of the thing inside of the thing inside of the thing, and then you see them doing like this on each other, and you know that it gives you a whole new appreciation for how a muscle is going short and long, and how, you know, little parts of it doesn't all collectively move together. We do learn anatomy from this very gross and global place, but it doesn't all go short and long at the same time, and there can be bits and pieces that are holding on for dear life, and they're like, no, hold on. And so it's not, I think that, you know, tightness means that we have to assess why it's tight in the first place. And then what is it going to take to basically relieve that structure its job duties in terms of generating that tightness for stability, for safety, for, you know, the stability motor control, all of that. Is it because it's over mobilizing that it's kind of like, I don't know about this? Or is it because an adjacent neighboring structure isn't necessarily doing its job, so now there's more coming down onto that one? I think there's a lot to take into consideration, and tightness definitely shows us kind of where, you know, we can see a person move globally, but then we can like really go for it structure by structure based on what's actually giving us that sort of palpable tightness that your patients can absolutely feel too. It's really cool to share that experience with them and say, ooh, hey, this is really interesting. I want you to feel how tight this is. And then they can feel it and they're like, I had no idea that was tight. And then, you know, you can work together to resolve it. And it's often not where their pain is, which is also really interesting. It's always really fun to find a painful structure and it's like, Play-Doh. It's lovely. But then, you know, something on the other side is tight. So yeah, I think it's a really fun topic. It's a fun thing to look at and, you know, figure out why you're doing what you're doing. I mean, that's it, you know, as long as we're comfortable, you know, we have to be comfortable telling our patients what we're doing. I think people get too comfortable with not knowing why they're doing what they're doing. So as long as we can put an end to that and say, hey, you know what, this is tight. This is why it's tight. Here's what we're going to do about it. Your patient's very involved and they can self-assess at home and it's great. It's patient-centered. It's perfect.
Awesome. Awesome. Danny, I remember meeting you and you like had parts of your body that were kind of tight. And you were talking to us about how doing some of the anatomy strategies that we do in ID, how it changed the way that your body kind of felt as far as being tight. And I know you're also in landscaping right now, so you're like getting like super fit. How do you think like the tightness, you know, conversation we have in ID is applied to you personally?
Well, I'd say a lot of it just kind of comes from not maybe, I guess, kind of moving through life kind of through a lot of compensation patterns. And kind of, I guess, jokingly kind of referred to it as like anxious muscles. So like muscles that were afraid to, you know, learn properly because they never had a chance to move properly in the first place. So, you know, so very definitely would say that, you know, through learning proper biomechanics, learning, or at least concepts as to how to be moving properly and whatnot, you know, like that definitely helps in terms of working at things that way. But again, like just to paying attention to what's tight and what's not, you know, so like if it's tight, it's probably either the muscles being overworked or not worked enough. And, you know, just being able to really just kind of like fine tune, focus in on those and center it back towards them.
Love it. Awesome. The last question that we had for the panel is about prone exercises and how to breathe in prone exercises. It's not different than anything else we teach in immaculate dissection. We tell people to do neck long chin, tuck chest, shoulders down, hips even, lips together, teeth apart, tongue on the roof to manage the 7 diaphragms and to keep spinal stability. And when you're on your belly doing things like modified Superman, when you're doing crocodile breathing, you have to remember that the biomechanical breath is 7 through 10, and it's expansion outwards and upwards on inhalation. It's called bucket handle movement. And so it doesn't matter if you're prone or supine, you're breathing laterally. And so the lateral expansion is what a lot of people are missing, that focus on getting the diaphragm to drop down so that transverse abdominis, internal abdominal oblique, external abdominal oblique can eccentrically load on the sides. You think of these major exhalation muscles, their muscle belly is on the side. It's not on the front, it's not on the back, it's on the sides. And so if transverse abdominis is one of the more important exhalation muscles, if not the most important exhalation muscle, and it's supposed to be antagonizing the diaphragm's breathing mechanism, their muscle bellies, where they interdigitate, is more posterolateral. So basically by doing more prone breathing, you're getting people to be able to understand lateral expansion on that posterolateral aspect. So a lot of our patients, they'll be like, okay, I'm getting ready, I'm really getting good at supine 90-90, and then you flip them over and they're like, oh, I don't want to go prone. And you're like, well, that makes me want you to do it 50 times more. And so it is challenging. People don't really respect sometimes how difficult supine 90-90 and crocodile breathing are until they do them authentically and really try to get it from the right place, where they don't go axial with the breath, where they don't push their belly out in an attempt to belly breathe, whatever that is. And they really learn the biomechanical breath. Really helpful to fully understand that's where it has to come from, no matter what position you are in. It doesn't change. If it's supine, if it's prone, if it's sideline, if it's squat, if it's deadlift, if it's hanging from a bar, if it's upside down, like it doesn't really change. And that's the comfort of why Anna kind of said we were broken records in ID. We tell you the same things over and over because we were hard-headed like you and thought that things were fancier than they are. They're not fancy. It's like when my husband takes on a breathing client and he's like, well, we're going to breathe and we're going to do this simple exercise called 5-10s, where you inhale for 5 and you exhale for 10. Do you know how hard that is for the majority of people? Because he says like most people 2 minutes later are asleep. It's like they're so exhausted and they haven't been able to focus on something simple. So they make their life more complicated, make it harder when it really comes down to something simple. And so in Immaculate Dissection, we're the same. Where do you start? At the flow chart. We give you flow charts. We tell you, look, follow the standard operating system. Don't think that anything is different. No matter what condition you give us, no one's going to get a pass. Everything's going to be consistently there. And people that are very cerebral will try to change it. Oh, well, what about if I'm on all fours? What do I do? No, it's still the same. Neck long, chin tuck, chest wide, ribs down, hips even, lips together, teeth apart, tongue on the roof. What about my patient that has ankylosing spondylitis? I don't give a shit. Neck long, chin tuck, chest wide, ribs down, hips even, lips together, teeth apart, tongue on the roof, as much as they can do. And so that's what's great about it, is that that's what makes us these amazing bipeds. We have this same kind of tendency towards normalcy with those cues, where we can really center or stabilize our center of mass in the foot and in the body by these cues. And hopefully we can make it simple so that it doesn't have to seem so complicated. Annie, anything to add to that, prone breathing?
No, other than, all of our movement patterns, it doesn't matter if it's prone or the Superman or anything, we'll always have someone usually inhale and then move afterwards. They're not, inhaling while they're moving and things like that. That's, again, a common thread, broken record theme of ID is you take your inhale and then you move after that when you have the most intra-abdominal pressure to work with, and then sort of budget out accordingly. And it's interesting because when you watch really good performers and singers and things like that, they do it too. They inherently do it. If somebody's going to like do a cool dance move or something, it's while they're singing and doing the prolonged exhale. There's like a slight pause when someone inhales and then they kind of get back to it. It's one of the reasons why I love working with performers so much, is because they're inherently doing the thing that, where we teach. I don't know why people have gotten away from that. I don't know. I think, again, it just comes down to kind of what you're talking about, of things just being overly complicated sometimes, or people making them overly complicated. But the breathing cues are, take a pause, inhale, then go about what you got to do. It just doesn't need to be more complicated than that. There's nothing crazy added to it. We have people moving and sort of budgeting that loss of gut pressure.
Yeah, I am so glad that you mentioned that, because I think it's such a disconnect for a lot of patients and even students in our classes, where they're used to like inhaling on the down and exhaling on the up, or eccentric is an inhale. And we're like, no, you don't want to be moving on an inhalation whenever possible. You want to inhale and then be moving on an exhalation. So if someone were to do a bicep curl, I'd have them inhale, then do the entire motion on an exhale, right? Or even maintain their inhale. God forbid they hold their breath for a minute. Like, you can maintain your intra-abdominal pressure for a minute. You're not going to pass out. Don't do the entirety of the movement holding your breath, but breath retention is a really important thing to train. So it's these pauses: inhale, pause, exhale, pause. And I'm really glad Anna mentioned that. In all of our ID courses where there's exercise strategy, which is 1, 2, 3, 4, 6, we talk about, even in the nerve floss pendulums, we talk about doing breathing cycles and being able to get your maximum intra-abdominal pressure before you move. Because if you're moving when you're inhaling, the odds are pretty good you're stealing your abdominal lumbopelvic stability in order to create a motion. So it's very, very advisable, like Anna said, to inhale first and then move. So on something like the panelist asked about modified Superman, which is a drill where you're on your belly and you're lifting up respective hand and foot. You would inhale before you start, and then lift, and then exhale as you're reaching. And because as soon as you start exhaling, you're losing gut pressure, you're losing stability. You're the most stable at the end of your inhale. So freeze if you need stability, re-inhale, and then move again. Danny, you have an awesome video on intra-abdominal pressure on our Instagram. Anything else to add about breathing mechanisms in prone?
Yeah, I mean, I was just really going to add, you kind of took it in that last second there, but basically just a lot of that though, you're the strongest when you have like that full ability of inhale there. So you definitely don't want to be doing any kind of movement or any kind of, anything where, weight can be kind of off kilter or so on and so forth, as you have less pressure actually holding you in. I don't know, you can kind of think of it as like a balloon, like the more inhaled it is, the tighter the pressure is, the more air you let out, the softer and squishier it is. You're trying to provide stability for these structures that are moving, and you want to have as firm of a surface or firm of structures as possible to really support everything and prevent any injuries from happening. So,
God, you made me remember when we used to do that in ID1 where we used to blow up a balloon and then like let it fly across the room. Just like,
yeah.
Exhale. Gosh, we got to bring that back. That was really, really good. I love that of controlling exhale. Like it's not just letting all the air out of the balloon. It's a controlled loss of air. It's a wonderful visual. Leave it to you to give us a visual. You are the king of that. So those are awesome questions. Panelists, thank you so much for these amazing questions. And then we love them. Keep them coming. If you think of them during the week, just email one of us and we'd love to hear it. Of course, this will be recorded for you so you can go back and watch it if you found it interesting. We have to share with you the fact that we have a product for you. Danny and Anna and I have been working on this for a while, and it's in relationship to our ID6 assessing movement subsystem courses. The movement subsystems were started by Andre Volimi, and then people like Tom Myers and other strategists have really developed coursework around these, the research done by Andre Volimi and Diane Lee. We have our own version of it, and it involves like gait analysis and the understanding of abdominal lumbopelvic stability and how it relates to the entirety of the body. And so ID6 is a course where we kind of push people around and see what their problem is. And then we start to hack into the system to help them with their problems with stability motor control. So I have that pulled up here. So let me just share that with you folks. It's our first poster. And so this is the ID and the anatomy of gait through movement subsystems. And we have 5 movement subsystems in the body: the intrinsic core stabilization system, the deep longitudinal subsystem, which is anterior to posterior on one leg. And then lateral subsystem is, of course, lateral movement in the frontal plane. And then anterior and posterior subsystems are for transverse plane motion. And this is all how we ambulate, how we move through space. We listed out for you the gait phases in case you need to learn the gait cycles and understand the gait cycles. And then Danny has listed out for you each gait cycle and which subsystem is the most important to assess for each one. And then we have our little cheat sheet that Anna created for you on perturbations and the relationship to the subsystems. If you've not taken ID6, I mean, I highly suggest it, obviously, for our online course, and even applying that tuition to an in-person course whenever you can. But this poster is fantastic. If you ever want to understand gait, this is how to understand it. It's through movement subsystems. And it's all really, the green structures that you see here are abdominal lumbopelvic stability, and then the red structures are what can interfere with it as antagonists. So Danny's created for you both primary and secondary synergists, the things that work together to kind of carry out the motion around the abdominal lumbopelvis, and then red and orange structures, which are primary and secondary antagonists, respectively, to get in the way of it. Like the first place is to look. So this course is extremely popular. ID6 has been something for online orders that we get a lot of orders about. We think it's a fantastic course. It premiered last year. We did 4 beta tests of it to try to get it as perfect as possible. And we think that, I really think the very first run was a nail, just nailed it last year. I think that we really got it down. And then we created a poster for the people, like, not only to get excited about taking ID6, but in case, you want something for your wall to kind of relate to. It's 24 by 36. It's going to be at a really great price. We're going to just pay attention to our Facebook and our Instagram this week. If you're on our email list, then we'll also email you out a notification that when we're releasing it on sale this week. It's going to be, we're going to have a reduced price for August, so you guys can get, several dollars off, so you can be the first run to see if, it's right for you. It's a gorgeous, gorgeous poster. It hangs up in my office here. We're so proud of it. And we think it's a product that you will use every day to look at relationships, to study relationships around the abdominal lumbar pelvis. And if you are interested in gait, which I'm hoping that you are, this is the way to understand gait. It's the only way to understand gait, is to study these subsystems and to really understand the different phases. We have an ID collaborative talk for $20 on this movement subsystem. We show this chart. So if you want to kind of get like a teaser, you can spend $20 first and learn a little bit about gait with us, and then you can invest in the poster. Anna and Danny, anything else to add?
Just that we're really excited with this, and we're excited for, people to have this in a place that they can refer back to, and hopefully it's around them when they're working. And it's been a while in the making, so that's cool to see it come to fruition. And it's also, I think, big visuals like this are so great to just support your patient education. And I know, in my office I have a lot of acupuncture charts, and my patients are fascinated with like looking at the channels and just showing me and saying, like, oh my gosh, what does this point mean here? And I think that it's a way to connect with people, even more than you already are. And so for somebody to go, oh wow, this is the whole line that I experience symptoms on, or, even if that's not necessarily what you're making your decisions on, but it's something that builds trust amongst your patients, because, they see that you get this, you get your, their way of thinking, and they can see it illustrated in yellow, green, and red, then, it's a boost of confidence for your patient, and really just sort of supports a healthy learning environment with your patients and clients, and just sort of the re-education that comes with a lot of this, a lot of these techniques. So I think it's a really cool thing. I think it's a cool thing that brings people together. I think it's a cool thing that sparks fun conversation and dialogues and really gets wheels turning. So couldn't be more excited about it.
Yeah, it's really a thing of beauty. Every time I come to the office, I'm like, gosh, dang, that is what I needed my whole career. And we didn't really find, there's some people that do some subsystem stuff, but it wasn't like this. It wasn't put out in gait terms. Didn't have the perturbations. It didn't have the different gait phases and relationship to them. It didn't have the primary antagonist, secondary I just didn't have it. And Danny and Anna and I think we filled in some gaps, and we really hope that this will help people with their understanding of movement subsystems. Danny, you created the gorgeous, absolutely unreproducible by anybody but you kind of art. Do you want to share anything about what it took to put this together and what you think of it?
Yeah, basically, it's just been really fun working with you guys and creating visuals with you guys, because, you guys have so much knowledge and so much, just facts and information that's, to be given out. And then it's kind of trickled out through the filter of, the visual representation of things. So, a lot of times, like, I've definitely found it, I don't want to say frustrating per se, but a lot more helpful when everything is all together in the same spot all at once. So basically this post right here is kind of a congregation of that, so it's all the information that you need there. Color coded simply, obviously playing off traffic lights, green means go, red means stop, and yellow means slow down. So, so it's just that very easy breakdown, should be easy as possible to, kind of understand when you kind of break things down in that sense. And I feel like simple fact of the matter though too is like, I don't know, coming into a doctor's office and, a lot of people, you can't really see what's going on underneath your skin, so this here, kind of has everything breaking down into what you need to be looking at the moment, as opposed to having to clean things out or sift things out just to focus on the one part that you need. So, so just a lot of it is designed, to just try to be as easy as possible to read. It has a breakdown as to what phases are activated in certain phases of gaits. So, you can cross-reference, the gait aspect as well as with the subsystems that are active in there. And again, like it'll just basically serve to enhance and help kind of clarify if there's any questions that anybody has towards the materials.
So happy with this. It couldn't have come out better. We're so excited about it. So we hope that you guys will want to be on the list forum to get one, but keep an eye on our social media this week, because we're going to do a blast. But if you want to be put on an email list, you can just email like I'll put my email here. It's drkathydooley@gmail.com. You can also do immaculate dissection at gmail.com, and we'll email you when they're ready to ship, which is probably going to be around Thursday. But we're trying to figure out some of the little sales taxi stuff and all that stuff to make sure that we, give you a really good price for it. But it's going to be a really cost efficient price. I think you'll be shocked at how beautiful it is hanging on your wall. And I think more importantly, it's going to really help spark your knowledge of understanding abdominal lumbo-pelvic stability and being able to create that in gait. I mean, I can't tell you, like we for the ID collaborative talk, I know the gait one was huge. Like everyone wanted to see it. Everyone wants to understand gait, and everyone feels very stifled by gait. And then we're looking at each other like, well, we understand gait. We understand gait because we understand movement subsystems. And if you look at movement subsystems and you look at things like the human getup, like how we progress neurodevelopmentally to get up to be able to ambulate, it's not really that complicated. Is people make it complicated because they don't know where to look. And so in ID, we teach you where to look, obviously, but also where the problem may be. And that is a really, really fun thing to be able to help you guys understand. So if you want to get good at gait, if you want to get good at movement subsystems, if you want to understand gait better and perturbations better, pushing people around better and seeing what happens, then we highly suggest investing in the poster. And then your next investment after that probably should be ID6 if it isn't already, because that course is the culmination of all the IDs put together and understanding gait mechanisms. So if you're a gait fan, the poster and ID6 are for you. And if it's too much out of your financial abilities right now, then we definitely suggest the ID collaborative talk for $20 on ID and the anatomy of gait. So $20 USD. So hopefully we can be of use to you guys. Hopefully you guys will enjoy the poster as much as we're enjoying the poster. And then we'll see you for Ask Us Anything in 2 weeks. We're doing them bi-weekly now. So send us your questions if you have them in the next 2 weeks. If not, we would love to see you live in 2 weeks on the Ask Us Anything talks. Any last words to share with everybody, folks? Danny, Anna?
Just thanks so much for kicking it with us on a Sunday evening and, sending really great questions. These were really fun.
Weren't they awesome? Yeah, they're really good questions.
Really fun talks.
Yeah. Danny, any last words?
Pretty much similar note right there. It was nice getting some fun, lively questions for today, and just as per usual, just fun hanging out with everybody on a Sunday afternoon. So,
well, we loved having you. All right, folks, thanks so much for your time and attention, and we hope to see you soon on an ID collaborative talk at Ask Us Anything or online with the ID coursework. Have a good weekend. Bye.